This is Neonatal Hypoglycemia by Cassidy Rush, Baylor University Nurse Midwifery Track. The objective of this presentation is to help the midwife identify infants at risk for hypoglycemia, recognize the symptoms, and identify guidelines to diagnose and manage this patient population. Neonatal hypoglycemia is one of the most common diagnoses that necessitates admission to the NICU, affecting 51% of infants considered high risk and 19% of infants overall. It is important for midwives providing care to newborns to be able to identify and treat neonatal hypoglycemia because untreated, it can lead to adverse neurological outcomes in the newborn. I introduce a case study to help us apply what we learned throughout this presentation. The patient is a male infant born via uncomplicated vaginal delivery at 39 weeks gestation with 9 and 9 APGARs. He is 1 hour old, LGA, and an infant of a diabetic mother. His physical exam is significant for lethargy and hypotonia. Hypoglycemia is low levels of blood glucose. Glucose is the primary energy source, and levels of blood glucose are dependent on supply and demand. Decreased glucose supply can be caused by things like prematurity, IUGR, hepatic dysfunction, or metabolic disorders. Increased glucose consumption is caused by things like LGA status, sepsis, or even IgM. Healthy term newborns store glucose as glycogen in the liver in the 3rd trimester. Once the infant is born and separated from the placenta, the infant must maintain a serum glucose level that supports neonatal brain function on their own. There is a physiologic low around 1 to 1.5 hours of life that stabilizes around 3 to 4 hours of life and is considered normal for a healthy term newborn. The healthy term newborn maintains their glucose levels by utilization of breast milk or formula, glycogen stores, and the creation of glucose. This population of infant does not have any risk factors for hypoglycemia and will feed soon after birth. Therefore, routine screening in healthy term asymptomatic newborns after an uncomplicated birth without any risk factors is not recommended. Identifying infants at risk is the first step midwives must take to ensure proper screening and treatment for hypoglycemia. Preterm and small for gestational age infants both have poor glycogen reserves at birth. Preterm infants also have immature counter-regulatory hormone systems, further increasing their risk for hypoglycemia. Perinatal asphyxia or stress is another risk factor for neonatal hypoglycemia because it can cause hyperinsulinism and increased metabolism after birth. Some facilities use a 5-minute APGAR score of 7 or less for an infant to meet this risk factor and qualify for screening. Maternal diabetes increases an infant's risk for hypoglycemia due to hyperinsulinism as well. LGA, or large for gestational age infants, are also at risk for neonatal hypoglycemia, but instead it is due to the increased calorie consumption needed to regulate their body temperature. All of these risk factors are typically included in facility protocols as initiators for newborn blood glucose screenings. Neonatal hypoglycemia can be symptomatic or asymptomatic. Symptoms can include lethargy, hypotonia, weak cry, apnea, cyanosis, jitteriness, and refusal or reluctance to feed. Symptoms are typically vague and nonspecific. If left undiagnosed or untreated, persistent hypoglycemia can lead to severe neurologic damage. Damage can be exacerbated by neonatal asphyxia. Symptoms can include seizures, intellectual disabilities, and attention deficit disorder. Many institutions have protocols for screening and management of newborns at risk for hypoglycemia. The American Academy of Pediatrics recommends screening all preterm and SGA infants for up to 24 hours after birth and all IDM and LGA infants for up to 12 hours after birth. The AAP has recommendations for protocol guidelines and states that asymptomatic infants at high risk should be fed within the first hour of life, and a plasma glucose check should be completed 30 minutes after the first feed. Plasma glucose levels should then be checked before routine feedings. Any infant who is symptomatic should be tested immediately. Testing blood glucose on a newborn should be done using a glucometer or lab specimen obtained from capillary blood in the infant's heel. It is important the midwife knows the proper collection technique and the appropriate places on the heel to puncture, as exhibited in the photo on the right. At-risk infants who are less than 48 hours of age would be considered hypoglycemic with a plasma glucose level of less than 40, and infants greater than 48 hours of age would be considered hypoglycemic with a blood glucose level of less than 60, according to the AAP. Per the AAP, infants that have hypoglycemia who can PO feed should be given 200 mg per kg of oral glucose gel and breast or bottle feed with a glucose recheck in 1 hour. If the recheck is still low, the infant should be admitted to NICU and receive an IV bolus of 2 mL per kg of D10W. Varney states that midwives should immediately confirm any glucose value of 50 or less with a venous sample and consult a pediatric provider. To wrap up this case study, as the midwife caring for this patient, we know that IDM causes hyperinsulinism and being LGA increases caloric consumption, putting this infant at very high risk for hypoglycemia. The infant is also symptomatic with hypotonia and lethargy. This infant needs a stacked glucose check and to be started on a screening protocol ASAP. Midwives should screen women for risk factors for neonatal hypoglycemia so that the infant is properly screened after birth. The midwife should consult a pediatric provider and follow AAP recommendations for diagnosing and treating neonatal hypoglycemia. Midwives should also be familiar with the signs and symptoms of neonatal hypoglycemia and available treatment options.